Thank you, Mr. Chairman, for this introduction. So moving from the male osteoporosis to the young woman osteoporosis. So this is my disclosure, and here, just in the coming 25 minutes, I'll try to review the challenges that apply to premenopausal osteoporosis in terms of the interpretation of the DICSA, terminology, diagnostic criteria, evaluation, and management. So starting with this familiar graph, the changes in bone density with age. We know that it's increased with the adolescent, and then we reach a peak bone mass. This peak bone mass, different bones have different peak bone mass, but generally the peak bone mass between 20 and 30 years of age, and then plateau will maintain. And then we have the general age-associated bone loss, which is approximately 0.5 to 1% per year. And then in women, as we said, there is a further bone loss at the period of the menopause because of the loss of the gonadal hormone. And then we resume the age-related bone loss, and then eventually we will back to the adolescent BMD. So if you look at the premenopausal years, these years is just considered years of a stable bone density, where with that we expect that the premenopausal osteoporosis is uncommon. And if you look at this fracture incidence, it is looking at the women below the age of 50, it's very rare compared to the women over the age of 50 or at menopause. Maybe that because the premenopausal or younger women, they have more muscle mass and they have low bone turnover, as we know, and they have less fall tendency. So just to influence our discussion, I'll present some cases, and maybe one of the cases with my colleague, he just talked about similar to this case. We have a 29-year-old lady. She previously healthy, or she's a healthy woman. She was seen at primary health care for backache since the delivery of her 4-month-old baby. Her image, trying to see if there is any vertebral fracture, there was no vertebral fracture. But because of this low density, it led to the bone mineral density, and it showed a T-score of -2.7. So she had isolated low bone mineral density, no secondary causes, and no fracture. This is versus the second case, which is a 43-year-old lady who developed acute back pain when she just carried a heavy box during her transfer to her new house. Image revealed 2 vertebral compressive fracture. However, her bone mineral density was normal. So this lady has fragility fracture, but normal BMD. So with these 2 cases, we have some diagnostic uncertainty. Who among them has osteoporosis? Whether the woman with a fragility fracture but normal BMD, or the other who has low bone mineral density but with no fracture. So what further evaluation for these ladies, and do they need treatment, and do you have to treat them, and what are the treatment options if necessary? So back to the osteoporosis definition. We know that osteoporosis, as we said, it's a skeletal disorder characterized by compromised bone strength that predisposes to increased risk of fracture among minimal trauma, which is fragility fracture. And this is, so the definition is applied to the second case who had fragility fracture. We may say that or label her that she has osteoporosis. However, the operational definition of osteoporosis, this is defined as osteoporosis with a T-score -2.5. And this T-score is compared to an individual bone mineral density with the mean value for young normal and the expression differences as a standard deviation score. Of course, this T-score and these definitions apply to the postmenopausal woman. However, this turn or cut point were never intended and should not be used to characterize the bone mineral density in the premenopausal woman. Why is that? Because the relationship between the bone density and the fracture risk is different in premenopausal women. This is the familiar graph that we see. In the x-axis, we have the T-score, and the y-axis, we have the fracture risk. And we have this different graph in different ages. If we notice that women above the age of 50, the fracture risk is related to the age as well as the T-score. However, women who is less than 50 years, maybe we expect that the fracture risk is low. However, it's in fact, we have lack of data, and the relationship between the bone mineral density and the fracture risk has not been properly or defined in prospective data in this age group. So the screening, because this fracture risk is not recommended, screening by BMD I mean, and however, the bone mineral density is called for when there is fracture or when there is an active ongoing secondary causes for bone loss. Despite that, we can say that the osteoporosis cannot be diagnosed based on the BMD alone. And why is that? If we look at normal, healthy young women, we see that it's follow a bell curve, which is a normal distribution, and 15% of these young women, they had an osteopenia or low T-score, less than -1, and 0.5% they have a T-score of less than -2.5, which is defined osteoporosis. So these healthy women, why do they have a low bone mineral density? This low bone mineral density may not signify an active process of bone loss. First, maybe they have suboptimal peak bone mass. They couldn't reach the peak bone mass, maybe because of genetic, which is account for 50 to 80% for the peak bone mass, or maybe they have a childhood illness that resolved now, and they do not have an active process or active bone loss currently. The other cause, they already not reach the peak bone mass yet. So when we do the peak bone mass, we have to attain what is the period of attaining the peak bone mass. Maybe it is in less than 20 years or 21, and they did not have reached the peak bone mass yet. Other thing, women who have small stature, their bone mineral density may be underestimated because the DICSA, it's measured the areal bone mineral density, which underestimates the BMD in the small individual. Furthermore, this low bone mineral density may be related to the physiological BMD changes during the pregnancy and lactation. You know, with the pregnancy, there is loss of the bone mineral density, approximately 3 to 5%. And why is that? Especially in the late trimester, when the baby's bone is mineralized, and it's take this mineralization from the skeletal, maternal skeleton. Further drop happens if the patient is lactating. And this drop in the bone mineral density may be reached up to 10%. And why is that? Because the calcium still continue to mobilize from the maternal skeleton to trying to form the milk for the baby. However, this is fortunately, a recovery will follow with the weaning. So if we measure the bone mineral density in these physiological changes, the bone mineral density does not reflect the actual basal bone mineral density of that lady. And that means that every bone mineral density or bone mass measurement in the premenopausal woman must be placed in the control of these normal and expected changes. And this have a clinical implication. Look at this graph. This is 100 women who were followed 12 months postpartum. And if we see that women in the upper two graph who nurse their baby for less than 2 months, there may be no much changes in their bone mineral density. However, those who lactate over 5 months of their baby, there is a drop in their bone mineral density, and even the recovery happens afterward spontaneously without even if they continue lactation. That means that low bone mass in a woman who's nursing more than 5 months postpartum can be expected to improve significantly by 18 months. So this is a physiological process that happens. However, unfortunately, maybe or rarely, this is low trauma fracture can happen, especially in the vertebrae, can occur in the context of these expected bone mass changes. And this is very specific. This problem is specific to the premenopausal, and we call it pregnancy and lactation associated osteoporosis, PLO or PAO. And it's very rare, fortunately, it's very rare, and it's just only described by case report or case series. The women present with low trauma fracture, spontaneous fracture, usually multiple vertebral fracture, and during the late pregnancy, late trimester, or in the lactation. A majority of these women, they have no known predisposing factor. And however, it's very important to identify this because in large cohort study, it showed that these women at high risk of subsequent risk of fracture. So how would we diagnose these women? There are some guidelines that was put by the ISCD, which is the International Society of Clinical Densitometry, and the International Osteoporosis Foundation. They've mentioned that, of course, the diagnosis is more certain or secure if we have low trauma fracture or fragility fracture. And osteoporosis, as I said, cannot be diagnosed based on the BMD for the factor that we said, and we have to be sure that we consider the timing of attainment of the peak bone mass in young and be aware of the physiological bone mineral density changes in the pregnancy and lactation. Both the ISCD and the IOF, they recommend to use the Z-score rather than the T-score. And we know in this age group, maybe they are very similar because we know that T-score is comparing to the young, healthy woman, and they are young. So maybe they are similar, but still they recommend to use the Z-score just to avoid the complication or the confusion with the T-score or the clinical implication of T-score that is applied to the postmenopausal. Some exception of these is the ISCD. You may use the T-score for perimenopausal, so more elderly premenopause, or the IOF also you may use the T-score, could be used for premenopausal women who known to have ongoing and active secondary causes that cause bone loss or fragility. The osteoporosis then applied to those with fracture, low trauma fracture, whether or not the BMD is normal or low, and if the patient has clear Z-score less than -2 or a T-score less than -2.5 with ongoing secondary causes for bone loss. The term osteopenia should not be used to describe BMD in premenopausal women. However, we replace it with the term that this lady has a BMD below the expected range of age. So back to our case, these will have isolated BMD and no fracture. According to the IOF and ISCD, she cannot be said to have osteoporosis. However, we will say that she has bone mineral density that is below the expected range of her age. And the second case is clearly she has osteoporosis. So who needs evaluation? For evaluation, the goal of the evaluation of premenopausal osteoporosis is to identify the secondary causes, especially the treatable one. And there are several secondary causes that is there. So both of these cases that we present, they need evaluation because evaluation is needed for women with low BMD, like the first one, and with women with fragility fracture, regardless of the bone mineral density. However, the IOF, they suggest to do the BMD in women who have more than one fracture, not only one. And these are the secondary causes. It includes anorexia nervosa, some of the endocrine causes like Cushing syndrome, hyperthyroidism, and malabsorption, and several causes of secondary. But the most common causes of osteoporosis in premenopausal is glucocorticoid excess, whether de novo, like Cushing syndrome, or excess intake, or premenopausal estrogen deficiency, premature ovarian failure, or many GI diseases like celiac, malabsorption, irritable inflammatory bowel disease, some medication, anti-epileptic, chemotherapy, and also, of course, steroid, primary hyperparathyroidism, vitamin D deficiency, severe, it may cause, or osteogenesis imperfecta, and I forgot to write the hypercalciuria, idiopathic hypercalciuria. Of course, after extensive exclusion of all secondary causes, we may call that is isolated low bone mineral density or idiopathic low BMD. So, and how often these secondary causes can be found? In a population-based study of women between 20 and 50, they see that we can find these secondary causes 90% of the cases. But in series of tertiary referral centers, it is only about 50% had secondary causes. So maybe in our centers, maybe 50% of the time, we cannot find a secondary cause. So with that, of course, when we try to find these secondary causes, we have to do a detailed history and physical examination. In the history, we have to see if there is previous fracture, even in the family, because we know that the peak bone masses depend on the genetic, and maybe it's run in the genetics, family history, early tooth loss, which may justify that there is a quality of the bone is low, and then it might justify some of the diseases like hypophosphatemic rickets or something. Kidney stones, because hyperparathyroidism, menstrual history, of course, and pregnancy and lactation, as we said earlier, eating disorders like anorexia nervosa, subtle GI symptoms. We may call for further investigation to exclude malabsorption like celiac, medication like steroid or other medication. Physical examination, of course, from the history, you might just look for this physical examination that is clearly for the Cushing syndrome, hyperthyroidism, and the rest. Initial laboratory tests include these, and these bundle of laboratory tests, in fact, can identify more than 50% of the secondary causes. The usual assessment of the bone health include the CBC, electrolytes, of course, the bone panel, which is the calcium, phosphate, and creatinine, alkaline phosphatase, the vitamin D, the thyroid hormone, it has to be in the bundles, the parathyroid hormone, as well as 24 hour urine for calcium and creatinine. And this is very important not to ignore this 25 urine collection for calcium, because idiopathic hypercalciuria can be found in approximately more than 25% of these young premenopausal with osteoporosis. So we'll do this initial laboratory, and further laboratory test is indicated what is seen from the history and physical examination. We can do further tests as listed. How about the management? The general measures is called for adequate nutrition, calcium, vitamin D, and exercise like any other osteoporosis. And of course, lifestyle, avoid the excess alcohol and smoking cessation. And of course, this makes sense, but unfortunately, it has minimal effect on bone mass, at least, but they are essential. It has been found that in one study that these calcium and vitamin D and general measures, it may improve the bone mineral density, but there is no fracture data. Maybe because no fracture data because of the risk of the fracture, in fact, in this premenopausal or this age group is minimal. However, addressing the underlying cause is very important, and if possible, and there are many studies that showed the bone mineral density improved when we address the underlying cause, and improve significantly, maybe, and you do not need pharmacological therapy. And these studies include the anorexia nervosa, we might go just nutritional rehabilitation, the hormone replacement in case of estrogen deficiency, the thiazide in case of idiopathic primary hypercalciuria, of course, and thyroidectomy and surgical for primary hyperparathyroidism, and gluten-free diet for the celiac. So these have approved that they improve the bone mineral density, but of course, again, no fracture data. So how about those with no secondary causes can be found? What we're going to do? Of course, we have to do the extensive looking for the secondary causes from the history, physical examination, and the initial lab. And if not found, we have to follow this bone mineral density. And if the follow-up of bone mineral density, maybe in a year's time, and if it is suggests that there is a drop in mineral density, it suggests that there is undiagnosed secondary cause, and we have to look for that. And if in the meantime, we have to optimize the bone health with non-pharmacological therapy, lifestyle modification, as well as, and then the therapy it's called for as the time passes. And of course, reassurance based on this available data, and as the short-term fracture risk is low in this age group. So we have to reassure them if the bone mineral density is stable. And at the menopause, this lady who present with low bone mineral density in young age should be treated aggressively. We may screen them earlier, maybe 5 years earlier than the screening time, like for 60 years of age, because low premenopausal BMD associated with increased risk of postmenopausal fracture. So we have to treat them, and it's a risk factor if they have a history of low BMD at young with no secondary causes. And of course, the bone-specific medication is rarely justified and is considered case by case for women with multiple fracture, one or more fractures, or if they have ongoing active secondary cause that have negative effect on the bone, or they have low BMD, extremely low BMD with a Z-score less than -3. And this as the pharmacological therapy, we have anti-resorptive or we have anabolic. However, the studies showed that bisphosphonate in general and the teriparatide, they improve the bone mineral density in premenopausal women with secondary osteoporosis. And these are the list of the secondary causes that it has shown to have improved the bone mineral density with the teriparatide or bisphosphonate. And there is a nice review done by Dr. Ferreri that these all the listed, the glucocorticoid-induced osteoporosis, and there is a lecture at the end of the day by Dr. Hanan for GIOP, and anorexia nervosa, chemotherapy, lupus, and these are the listed secondary causes that showed improvement with the teriparatide or bisphosphonate. However, they are only approved for the glucocorticoid-induced osteoporosis. We have, it is by the FDA, but other secondary causes is not yet approved, but it has been shown to improve the BMD. And unfortunately, there is no data to show that treatment with BMD, with the bisphosphonate or teriparatide prevent fracture in premenopausal women. So far, we have that they improve the bone mineral density. Of course, some special consideration we have to take into account for the bisphosphonate, the long-term effect on the bone health. We know that the bisphosphonate, they accumulate in the skeleton, and they are characterized as a category C rating for safety in pregnancy, and it is unknown effect on human fetus. However, saying that, there are more than 50 reported cases of normal pregnancy outcome in the fetus with women who previously were treated with a bisphosphonate. Regarding the teriparatide, there was documentation of used epiphysis if it is used in younger women less than 25 years, so it should be avoided in this age group, and the treatment plan post the teriparatide is unclear. And there are some few cases that they treated with the teriparatide, it's not followed by any anti-resorptive, and they remain their bone density as well as long as they have the menses. And some they were giving bisphosphonate for a shorter period of time. And whenever we use the bisphosphonate, it's usually the plan to give it a shorter period, like 2 years or 3 years, if possible, the shortest that we can. How about other anti-resorptive? The SERM, raloxifene, it should not be used to treat the bone loss in premenopausal women because they block the E2 receptors action on the bone, and they will lead to further bone loss in menstruating women. The denosumab, the efficacy and safety is not defined in the premenopausal women, and they have category X in pregnancy because they have toxicity for the primate. So back to our cases. The first case, who had low bone mineral density. In fact, we looked for the secondary causes for osteoporosis, and it was not found. Since we know that she had nursing her child who's for 4 months, we said maybe this is a low bone mineral density that is related to pregnancy and lactation. So just general measures was ordered for this lady, well, with adequate nutrition, vitamin D, optimized vitamin D, and we monitor her bone mineral density, that it showed that it's improved and remained stable. The second case, the lady who has fragility fracture and normal bone mineral density. In fact, she had her menarche at age of 13. She had 3 grown children. Youngest is 14 years of age. She had secondary amenorrhea for 11 years after her third child, and she has never been evaluated for this amenorrhea. Her family history is positive for hypothyroidism and diabetes. She's a businesswoman who had shisha smoker. She hadn't noticed any loss of height. Examination showed that she's a slim lady with a BMI of 24, no blue sclera, she excluded the osteogenesis imperfecta, goiter, they had goiter but was euthyroid. She had lumbar lordosis, but no tenderness, and there was no joint inflammation and hypermotility. However, with this history of amenorrhea, the laboratory confirmed that she has low estradiol and high LH and FSH. So with the diagnosis of premature ovarian failure, so with the general measures, we give her the general measure, adequate calcium, vitamin D, and nutrition, and we advise her to smoking cessation, and we started her with hormonal replacement therapy till the age of the, at least she has 7 years, till the age of the menopause. So in summary, screening for perimenopausal women is not recommended, and the diagnosis of osteoporosis in the premenopausal woman is most secure if low trauma fracture or there is ongoing secondary causes. When we interpret the bone mineral density, we have to interpret it at the context of the growth and reproductive event, and it is crucial to assess for secondary causes of bone loss in this patient too, and for treatment. Drug treatment is rarely justified for this age group or for isolated low bone mineral density alone. We have to repeat the bone mineral density in a year or 2 years' time to assess for ongoing loss. And then pharmacological therapy can be considered in patient who has a fragility fracture, or she has ongoing secondary causes or long-term glucocorticoid, because this is medication that causes osteoporosis. And then document if there is documented accelerated bone loss on the follow-up, or in patient who's premenopause but elderly premenopause or perimenopausal. The anti-resorptive drug, antiteriperitide, increased the bone mineral density in premenopausal women with various causes of bone loss, and we said the list of the secondary causes that has been shown to be improved. The bisphosphonate and teriparatide are FDA approved for premenopausal women only in the setting of the glucocorticoid-induced osteoporosis, but there is no fracture data in this population because the fracture, anyway, it is low, and because this low fracture, I think there will probably never be any data. With that, I just conclude, and thank you.
Okay, thank you, Dr. Selwa, for your excellent presentation. So now for the questions, please join. Okay. So far, I have only one question. Okay, there is one question to Dr. Muhammad. Shall we do bone density in men if fracture occur below age of 50?
Fracture, clear now. It has been recommended if you have a virginity fracture, osteoporotic low trauma fractures, to proceed with the BMD testing in those kind of patients. First, also, it's not only for establishing the diagnosis, because you are already establishing the diagnosis, but also that will guide you and help you regarding of monitoring of the therapy.
Okay, thank you, Dr. Muhammad. Another question. What about sickle cell disease patient, young, who came with a low bone mass, Z-score less than -2, with no history of fractures? How would you manage such a condition? Also in men.
In this kind of patients, if you are talking about male with osteoporosis and you figure out that they have a secondary causes, which is, as we mentioned earlier, that it's account for half of those cases having a secondary causes. So we'll treat the cause. So having a gluten-free diet in addition to adequate calcium and vitamin D supplementation, showing that things will improve significantly in their BMD values. So you can repeat that in 1 to 2 years' time, and you can observe the BMD that will be gained significantly with the just gluten-free diet, calcium, and adequate vitamin D supplementation.
Okay, thank you, Dr. Muhammad. Question to Dr. Selwa. Does vitamin D deficiency put the pregnant lactating woman at a risk of pregnancy and lactation-associated osteoporosis?
mineral density. But the entity of pregnancy and lactation, maybe this is one factor that would signify that low bone mineral density in this age group.
Okay, thank you, Dr. Salwa. Question to Dr. Muhammad. What is the percentage of treating osteoporosis males in Saudi Arabia? What is the percentage of treated osteoporosis males in Saudi Arabia?
I don't have to. And actually, it's good to highlight that we have more. We have to have more of epidemiological studies. It's not only about women, but in men. When we try to search for the literature in the last 10 years, we don't have much of data about epidemiological studies that's specified for men. We have the data that has been published in 2012 by Professor Sadat, where they addressed prevalence of osteoporosis in the kingdom, as mentioned, that it has been highlighting that those osteoporotic in the kingdom based on the data in 2012. But hopefully we'll have in the near future epidemiological studies about vertebral fracture, hip fractures in men specifically, and what are the prevalence of those with the advances that we've got over the last decade.
Okay, thank you, Dr. Muhammad. Question to Dr. Salwa. Denosumab is already approved in glucose-induced osteoporosis in Saudi Arabia. Can it be used for premenopausal with glucose-induced? So denosumab, can it be used in premenopausal ladies with glucose-induced osteoporosis?
With glucocorticoid, you mean?
Yeah.
In fact, yes, with some precaution. It's categorized as category X because this is a productive age. But certainly there are some studies that it has been approved, but they were this age for premenopausal. But it's, as I said, it's category X. It is not defined about what is the outcome of the after the pregnancy. But it is, yes. And there is a talk about glucocorticoid-induced osteoporosis, inshallah, this afternoon.
Thank you, Dr. Salwa. I think we have 2 more minutes, and we have a question to Dr. Salma. If patient young and started on osteoporosis medication and got pregnant, should we stop the medication during pregnancy?
In fact, when we consider the medications very hard justified for this premenopause, unless she is in severe multiple fracture or very low bone mineral density. So with that, it is advisable, but it's not based on no data. It's advisable just to postpone the pregnancy in this period. If the pregnancy happen, then we only, if they approved only to do the bisphosphonate, we know that there is no data, but however, there are some case report that the bisphosphonate was, the outcome was normal.
Okay, thank you, Dr. Salwa. Does hormone replacement therapy is enough to prevent further fractures in females?
What is it?
Does hormone replacement therapy in females enough to prevent fractures?
What is it?
Hormone replacement therapy
Hormone replacement therapy
in females.
are good. There is no data, but we know that it has very good effect on the in the bone. They are positive. They are very efficacious. So, however, we have no data for fracture, but this is assuming that improving the bone mineral density will lead to a prevention of the fracture. There is no fracture data at all for premenopausal women.
Thank you, Dr. Salwa. What about recommendation? This is also a question to you. What about recommendation in regarding the next pregnancies in women who've developed pregnancy-related osteoporosis?
In fact, for pregnancy and lactation, this is a special entity. They are at higher risk of developing osteoporosis, but there is no way just to prevent it, and there is no predictable factor that we can predict which woman is going to have another fracture, but they are at risk. So they have to optimize their vitamin D and calcium, and we'll pray for the best.
Okay. I think because of time, we reach our limit, 11:30, and for Jum'ah prayer. I would like to thank both Dr. Salwa and Dr. Muhammad for their excellent presentation, and thank to the audience for their participation and listening. thank you all, and we will come back at 1:15 after our Jummah prayer. Thank you.